Wife, huh? I'll add you and everybody else to the praise there. This one's by Nero X. It's called Osei.
Come the star. Yamiyede. Wumbo no se. Yamiyede wumbo no se. Aba, you the wumbo me. Yamiyede. Ajamisha na mesake. Anya nyame na waya. Gana fu wonka. Hey. Adamani na do na benye. Anya nyame na waya. Gana fu wonka. Hey. And I met Tassa. That's your mother body. We are. What you with the food? Sunday, Mumu, I not do Morocco.
Will follow you, especially when you tune to 99.7 FM on a Sunday afternoon. That's right, let's gather on the dial 99.7 FM, me Nortey by nature. Program is Ultimate Health, your ultimate guide to healthy living. Listen every Sunday, 2:05. If it impacts on your life, your well-being, your health, indeed your wealth, we will most definitely talk about it and bring in the top-notch practitioners, professionals into the studio. Today we're continuing with our Breast Cancer Awareness Month. Yeah, I managed to grab a pink shirt. Kind of pinkish, yeah? Pink October. And I'm spending some of the time with professionals from the International Maritime Hospital in Tema. Today I have again Dr. Anita Uswefriye, resident oncologist. Dr. Charles Ansalabi, he's a general surgeon. And Dr. Essie DeGraff Johnson. She's a radiologist with the IMA Hospital, as we call it, in Tema. If you have any questions, concerns, breast cancer awareness, early detection, screening, signs, symptoms, diagnosis, and beyond. We're going to try and do the full spectrum today, but we don't mind taking our time and getting it right. So, my guests, you're most welcome to the studio.
Thank you.
Right, Anita, Essie, and Charles. Right. Today I have another gentleman with me in the studio, so I'm not that, kind of endangered or outnumbered. But you're most welcome.
Thank you.
How's IMA? How's the International Maritime Hospital? Cool.
Yes.
Oh, you don't want to talk about your place?
So it's all about Pink October.
It's Pink October, but I'm asking about where the place, IMA.
It's
cool.
It's cool. Yeah.
It's a good place.
And we are trying to create the awareness about breast cancer.
A good place. If you are selling IMA challenge, I'll go and buy Wachi. Right, but IMA is a lovely facility, and again, all public facilities, in fact, public and private facilities are stepping up, stepping on the accelerator when it comes to breast cancer awareness, especially, particularly, and emphatically in October. Last week I had Anita here with me, one-on-one,
Yes.
Okay, I had it all to myself, but today the bosses didn't want to allow that. But we spread the spectrum. Now you're a general surgeon, Charles.
Yes, please.
Okay, so you are into the chop cut.
Exactly.
What frightens people most, and it's topmost of their mind when they hear breast cancer. But there's a whole range of things before we might even get to surgical intervention. Am I right?
Yes, that's very true.
Okay, so we'll do the full gamut. Feel free, each of you, to chip in. Anita, last week we did quite a bit of it, education, right?
Yes,
Risk factors. We talked about how, we are aware that every year, annually, we get about 4,000 Ghanaian women diagnosed with breast cancer. And sadly, we lose about half of that number every year. That is alarming, right? We also learned that about 70 to 75% of our women present at an advanced stage, which leaves us very little to do, even though we have the crop of professionals like I have in the studio, right? So the key, the game changer, is early detection. Catch it early, and then you can do much more, and you can impact on lives of individuals and indeed their families and loved ones. So early detection was key. And then, Anita, you took us through some of the signs and symptoms we should be looking out for. We talked about breast self-examination. We talked about clinical examination. Right. You want to recap on any of those before I bring in the others in?
So I think I spoke about the breast self-examination, the fact that women know their bodies, they know their breasts, so it's easier for you to assess your breast at home. But unfortunately, it depends on your skill. So I would advise the women out there to always come to the hospital. Right now that is Pink October, with all the awareness, there's free screening going on, especially even in IMA. So you can come where the professionals are there. We tend to teach you the right thing to do, because I spoke about the fact that people just examine the breasts and they even leave the axilla, which we call the armpit. Yes, so we take you through that. And I spoke about also when it's best for you to come around. I mean, if you are a menstruating person, like you are still in your you are premenopausal, you are still menstruating,
right?
So about 3 to 5 days or 7 days after your menses is ideal, because around that time the breast is less lumpy and not tender. Tender means it's not painful. So we get to, have good access.
So the timing is important.
Yes, examine the breast well for you.
Okay, right. Clinical breast exam is when it's being done by a qualified professional.
Yes.
Right. Does it follow the same basic procedure?
It does, but because the person is a professional, we have a way of examining. I've seen women who examine their breast and they actually hold the breast in the other palm,
right,
and they just touch it. But that's not how it's done.
All right.
Yes. So when you come to the hospital, ideally when you are examining, the breast should be against the chest wall. So we have a way we examine so that we are able to pick up any lump. So it's better a professional does it for you.
You're literally pushing the breast against the chest wall and feeling for the lumps.
Yes.
Not holding the breast.
People hold it in the other palm, like people who are, who have a lot of breasts, like Basti.
Right.
So because the breast, the breast is full, they tend to support it with this, and they just touch. I've seen people, people do that. But when you do that, you can easily miss a lump.
Okay.
Yeah.
Dr. DeGraff Johnson, it looked like you were going to add something when I was talking about the position and how people would, checking their breasts.
Yes, I was going to chip in and say that with the examining with the fingers, you're not supposed to be.
Just a sec. Abeku, can you adjust her microphone? It's not that loud. The sound. Yeah. Go ahead.
So with the examination with the fingers, you're supposed to be using at least 3 or 4 fingers.
3 or 4 fingers.
Yes, and not with the tip of the fingers. It's supposed to be somewhere there. This aspect.
Right.
Fingers.
Okay, not your fingertips.
Not the tip.
Right.
The finger
Right.
itself.
Okay.
Yes, and then you examine, palpating or pressing it against the chest wall.
Okay.
Softly, not
Softly.
anything to causing harm or to causing pain.
Okay.
Yes.
Right.
And then it's supposed to be in a manner, so you can start from the nipple or the areola,
right,
going in circles all the way to get into the axilla.
Okay.
Then there's one that
the axilla being the armpit.
Yes.
Right.
And then you can start from your below the clavicle or below your collarbone.
Your collarbone, right?
Yes, coming down in a straight manner all the way to your nipple. You
So
move a
essentially that
section-
includes your chest.
Yes.
In a way, coming from the collarbone downwards,
Yes.
there's a part that you call your chest,
Yes.
right?
Yes.
If you were wearing clothes, then that's a little slightly above your neckline and then coming downwards.
Below the neckline.
Below the neckline.
collarbone,
Okay,
the-
right. Okay.
Yes, and
Right.
then coming down to your nipple. You
Okay.
do that all the way till you examine the whole breast.
Mm. Okay.
Or you can go from the inner part
Right.
in a horizontal manner
Mm-hmm.
to the armpits,
To the armpits.
stepwise. So from the first line, then you get to you go below a little to the second, all the
Okay.
way to the armpit, from the inner part of your chest to the outer part, and then don't forget to examine your armpit
The
as well.
armpits.
Yes.
Okay. So you're looking at that fleshy part that is actually your armpit. And you're also still looking out for lumps
Yes,
or
lumps
any
or
growths or
nodes.
anything
Yes.
abnormal there.
Yes.
Doc,
Right.
yeah.
So I also want to add that. So anatomically, the breast is starting from the second rib.
Okay.
So it explains the fact that you have to start just below your clavicle.
Okay.
And then it goes to the sixth rib.
Clavicle being your collarbone.
Exactly.
Okay, what we used to call the Rollins chain. My listeners would like it straight, blunt.
So
Rollins chain.
that's the vertical part.
Right.
And then the transverse or the horizontal aspect,
Mm.
it starts from the sternum.
Okay. The
So-
middle of your chest.
Exactly. The middle of your chest to
Outwards.
outwards to
Left
your
or
axilla, to your
right.
armpit.
Yeah, okay.
Exactly. So from the second to the sixth rib,
Mm.
and then from the lateral aspect of your sternum
Mm-hmm. Okay.
to your axilla, that's
Okay.
where the breast is.
See, I brought a surgeon. It's like bringing a lawyer into the studio, but I'll dissect him, right? Abeku, can you please just check AC's microphone there? I'm not getting, when she speaks, it's not the same. Right, okay, so that's examination,
Exactly.
all right? And that should pick up, if you pick up anything, what are you supposed to do?
So,
Mhm.
you know, the whole thing about breast examination, once you pick up a lump, whether you are at home or you are in the hospital, for instance, if you are at home, the next thing to do is to see a clinician.
Okay.
So you go to your primary care physician.
Mhm.
Then the primary care physician is going to do the proper clinical breast exam.
All right.
So with the proper clinical breast exam, after that is done,
Mhm.
then the next thing is to do the imaging.
Right.
And then after the imaging, you do the biopsy.
Okay.
So we call it
Wait. You're really, on your pedals there, okay? Now, you do a clinical breast exam done by a professional.
exactly. Sure.
And then you move to imaging, which means for us lay persons, whether we have breasts or not, you are taking pictures and developing or getting pictures of what the breast tissue looks like.
Exactly.
Okay. Now, for the lay person listening to us, imaging could be what? Ultrasound. It could be what and what?
It could be mammogram.
Okay. I intentionally went that way so that they see that it includes all of these things. Papa, we will see imaging. Right? So, imaging is actually capturing pictures. It's giving me echo. Right. Capturing pictures of breast tissue
Yes.
and being able to analyze that.
Sure.
To
exactly.
see what actually is there, right? The
Yes.
screening is feeling, palpating, or whatever words you use, right? You get a sense that something is there, and then you follow up with the imaging to confirm what is there. All right? So, ultrasound. What else?
Mammogram
Mammogram
and MRI.
and MRI.
That's for high risk individuals.
High risk individuals. Okay, let's pick up the pace a bit. Last week, Dede shared from Maryland that she does an annual mammogram, and she does a 3D mammogram because she has dense breasts. Okay, I was reading last night fibrocystic breasts and dense breasts. What's that? Can you just bring the microphone back? Yeah.
So anatomically, the breast is made of fibroglandular tissue,
Mm-hmm.
and then it's made of fat.
Okay.
It's been noted that women younger than 40
Okay.
usually have more fibroglandular tissues than the fat. So basically the composition of the breast is made of fibroglandular tissue and then breast. So depending on the percentages, some may have more fatty breast than more fibroglandular tissue, and then some may have more fibroglandular tissue than the fatty tissues or the fat in the breast. And because with ultrasound we are using sound waves to investigate or to image the breast, and then sound waves, they better pick up the masses or these nodes that we can palpate on the breast screening or breast examination from the fibroglandular tissue and even in the fat tissues as well. But then if your breast density or your breast composition contains more fibroglandular tissues, using the mammogram you may miss it because the breast mass or the breast lesion may appear as the same density as your normal breast. So it may be missed and it could be taken as normal. Meanwhile, at that point in time there was something there and it could have been picked earlier than it's moving on to something.
So because you've moved a notch upwards in the examination and investigation process, right? You're now sitting before a professional who is qualified and now can determine which of these imaging options is best for your situation and your type of breast and so on and so forth. And they may use multiple of these imaging options. Okay, folks, if you just joined us, it's 21 minutes past the hour 2 on Joy 99.7 FM. We're getting the basics and then we'll go into a bit more detail. Breast cancer awareness, early detection, signs, symptoms, diagnosis, and more. If you have any questions, concerns, call us 030-221-6541. Last week, Ilyasu, you shared with us your situation and your wife is undergoing treatment after about a 6-month period of investigations, right? You were pretty anxious about that. I'd taken your number. I had a packed week, but after today, I will get back to you so that we can follow up what is happening to you. Your anxiety also impacts on your wife and everybody else. So thanks again for sharing last week, but we have your details. We'll get back to you on that. If you have any questions, concerns, experiences, share them with us on Ultimate Health, Joy 99.7 FM. Okay.
Joy 99.7
So imaging
FM.
will get us closer to a confirmation, right?
Yes.
All along this spectrum, we haven't said you have breast cancer.
Not yet.
We are, should I say, firming up and getting more conclusive on what we are following up.
Yes.
All right. Now, General Surgeon, you got to the point where you were ready. You had gotten into biopsy, right? My listeners are very discerning and very particular. That's why I slow you down. But then you mentioned after imaging, are you suggesting every woman will get to biopsy, or let's understand this step to biopsy?
Right. So.
All right. Sorry. You want to come in before? Okay, go ahead.
So with the imaging, depending on what we see, we make recommendations or we classify what we see.
Okay.
So that if we don't see any, sometimes we tell you that the mammo you did wasn't enough, so do a complementary ultrasound.
Okay.
And then there's another grade that will tell you that, okay, we did not see anything, so you don't need to do anything, you are fine.
Okay.
Another one will tell you, yes, we saw something, but then it is benign. It is not something you should worry about. It can be there and then you will live with it, nothing will happen.
See what I don't like about you people? Benign, non-cancerous. It's not cancer. But it is still a lump or something.
It's still a lump,
but it is not cancerous.
It is not cancerous.
And you are able to say that conclusively to some women.
Yes.
Right?
Yes.
Okay. So when you hear benign, please, right? It is non-cancerous. Yes, go ahead, please.
And then there's another grade that will tell you that, okay, this looks more benign than more cancerous.
Okay.
But then let's do watchful waiting, or let's examine again with the ultrasound or with the mammo in about 3 to 6 months' time.
So in a sense, you are under surveillance.
Yes.
We are watching, monitoring
Yes.
what is happening to what we found.
Yes.
But we've made a tentative conclusion that it is likely to be benign.
Benign, yes. So at that stage, it's actually probably benign. So we give you a duration, we recommend a duration that within 3 to 6 months, come back and then image again, and let's see if there's been a change in size, there's been a change in composition, or there's been a change in the margins of the lesion, and then afterwards we advise accordingly.
Okay.
Yes.
Great stuff. 24 minutes past the hour 2. So far, it all sounds very user-friendly, calm, quiet. No. So we're good to go. And this is communication, confirmed for me, Dr. DeGraff Johnson. This is communication you are having directly with the woman who is being assessed, investigated. Or will you, you're a radiologist, right? Okay. Who is having this dialogue with, or will the doctor who referred for that assessment, how is that communication handled?
So, it's a report.
Okay.
That I would write.
You would write?
Yes.
A radiologist's report?
Yes.
Okay.
And then it will be given to the client or the patient to be given to the doctor.
All right.
But sometimes I may have that interaction with the client or the patient to discuss what is in the report.
Okay.
So that they will go and see their clinician.
Okay. Resident oncologist, Anita, darling dearest Doko. Listen, okay, so there's this communication. The reason I'm asking is that when you give something regarding this subject of cancer, in this instance, breast cancer, and you say, go give it to your oncologist or your doctor, it's almost like, what, are you told not to open it?
It's not clipped or
it's not
sealed.
Okay,
or
so the likelihood. I mean, even
yes,
when they say prohibited, do not. That is when. That is when. Yeah. My listeners will confirm in a sec. But that is when you want to know, and you may not interpret things properly. All this benign, watchful waiting, surveillance, and all that. Charlie, your heart is beating. Right. So. A bit about this communication. There's a report from the imaging, right, which stemmed from the earlier screening and the steps we mentioned already, listeners. All right. So now there's a report which is stating what was found.
Yes.
And then decisions or recommendations for follow-up steps.
Yes.
Okay. Yeah. So we are at your point now.
So most of the patients walk into us with their reports, and as you said, they've actually read it. They know what is there. So yesterday, I had a clinic and I saw a woman who has had a mammogram.
Okay.
And it was BIRAT 4, which is suspicious of malignancy. So their stage is what Dr. DeGraff explained.
So she's been ranked or staged?
Yes, exactly.
And you're mentioning?
Yes. So it's from 0 to 6.
Okay.
What she was grouping. So hers was BIRAT 4.
Okay.
That is whatever they saw is suspicious of malignancy. So she came to me. She had read it. And usually when they come in like that, the anxiety is there.
All right.
Because they've seen malignancy. People check their phones and they know malignant means cancer.
Okay.
So when she came, I assessed the breast again because I wasn't the first person that examined her breast. Yes, so I had to assess it. When I assessed it, I told her that looking at the breast examination findings, so we have something we call clinical staging. When you examine the breast, you stage it clinically.
Okay.
So staging is like the extent of whatever is going on.
Okay.
So she had some changes on the skin aside the lump.
Okay.
So we stage it, clinically, but I'm not supposed to tell her all that.
Right.
So based on the staging and the mammogram she came with, I now have to refer her to the surgeon for a biopsy.
All right.
Yes.
So biopsy comes into Charles's lab.
Yes.
Right. Okay.
Yes.
Now let me just clarify. You used a phrase, suspected malignancy.
Yes.
All right. And then you still went on to some steps of staging.
Yes.
Clarify that for me, as if we're in court like last week. Okay. Please, I've come to you. All right. I've followed everything I heard on Ultimate Health. So I'm following the steps, screening, and I hear now suspected malignancy. Where am I in the scheme of things? Can I go backwards to, you are actually fine?
Okay.
Right? Is this moving closer to what I don't want to hear, even though it could still be early detection and there's still a lot that can be done for me? Suspected malignancy, what's that?
Okay, so most of the times with the suspicious of malignancy, it means that there were things that were seen from the mammogram.
Okay.
Sometimes they see a speculated mass, like a mass. The radiologist will come in afterwards because that's the area.
Yeah.
But they see a speculated mass at a portion with some calcifications. They have their terms. So all these things, based on her expertise, they grade it.
Okay.
So mostly when we see and we examine the breast, the patient will need a biopsy done.
Right.
Honestly, for breast cancer, you can't tell a patient that the patient has a cancer unless a biopsy has been done.
You just made my day. Years ago, I had a client. Of course, I'm a clinical psychologist, but she was in so much despair, despondency, fear, everything. Right? And she said she had been told that she had cancer. And I asked her, was there any biopsy done? She said, well, the gentleman saw her. I said, well, what I can do is redirect you, okay? From what you are sharing with me, unless you've chosen to hide it, we haven't gotten to the point of a conclusive diagnosis. This is exactly what Anita is saying. A biopsy must be done. Despite what the radiologist has seen in the imaging, right? Match that with all earlier results and, should I say, presentations. Then back to the oncologist who now does some clinical staging and then needs to further go to the superior court. Right? Chaired by
Dr. Labi.
The surgeon. Folks, I hope you are following my laborious steps, okay? So now it goes to the surgeon for the biopsy. Let me just go through my WhatsApp. This is Ultimate Health on Joy 99.7 FM. We're still doing Pink October breast cancer awareness, early detection, signs and symptoms, diagnosis. In the studio with me from the Hospital, International Maritime Hospital, Tema, I have Dr. A.C. DeGraff Johnson. She's a radiologist. They do all the imaging and stuff. And they're also clinical radiologists. What are they? The ones who do
the ones who do
the radiotherapy.
Radiotherapy, that's under oncology.
That's under oncology. That's right. Right. I was coming backwards, right? And then I have an oncologist, right? She deals with all the communini in the cancer and all that. And then we have a surgeon, right?
Exactly.
Dr. Charles Ansa Labi. Right. Okay. So we've gotten to the point of biopsy. Let me do a biopsy on my WhatsApp box. This is Oye Nafienya welcoming us. Oye, you're welcome. I thought I saw a couple more. Nortey, is imaging also the same as X-ray?
Yes, it's the same as X-ray.
Okay. Right. I wanted to.
So we have X-ray, ultrasound, mammo, CT, and then MRI, and then some dynamic study or fluoroscopic studies.
Okay. Right. Imaging. We are looking into the body, so to speak, with different techniques. All right. Okay. WhatsApp is 055 11 11 997 if you want to share. And shortly I will activate the phone lines. Or let me do so now. 030221 6541. Dr. Ansalabi, so we've come to you, biopsy, right? This seems to be a very critical step. What's a biopsy?
So, a biopsy is when you take part of a tissue,
right,
or the whole of the tissue,
okay,
and then you subject it for histopathological
just
analysis.
Speak up a bit. Yep.
You take a tissue, either part of a tissue or the whole of a tissue, and then you subject it for histopathological analysis. So you are taking the tissue or part of it, and you are taking it to the lab, to the pathologist, to check what it is.
Right. What is it? And is it troublesome?
So the pathologist will now tell you that, what you are suspecting, it's either a cancer or it's not a cancer.
Okay. So once you take a sample of breast tissue, right?
Yeah.
In this instance, we're talking breast tissue.
Exactly.
In another instance, it could be other tissue, but the biopsy is really taking a sample of tissue because we're talking about abnormal cell growth, right? And you're taking a sample out to study in lab conditions.
Yes.
Right? And the pathologist is specialized in that.
Yes.
Yes.
He or she will look at that and then also, like AC, give you a report.
Yes.
Okay.
The pathologist will also give you
a biopsy report.
Yes.
It comes back to you.
Comes back to the surgeon.
Right.
So it's not the duty of the surgeon to stage the disease.
Okay.
Well, the disease can be staged by the oncologist and then the surgeon at the same time.
Okay.
So once you stage the disease, then you go and look at the risk factors. So in management of breast cancer, you look at triple assessment.
Okay.
That's the history and physical examination.
All right.
Anytime a patient presents to you, you want to take the history and physical examination.
Okay.
So once you are done with the physical examination, then the imaging, which is the breast ultrasound or mammogram. After the imaging, then the surgeon will do the biopsy. So once the surgeon gets the report of the biopsy, the surgeon is now going to stage the disease.
Okay.
And see if it's early disease.
Right.
Or it's regional, just in the breast.
Okay.
And or it has spread, but the spread or the metastasis, as they call it, will also depend on other imaging studies you are going to do.
Right. Okay. So at this point, and so that our listeners stay with us, and Debbie in Dede in Maryland says that the audio of our YouTube is ahead of the actual track or where we are. Right. Do bear with us, Dede. I'll see if there's anything that can be done about that. Abeku, if you have some buttons you can push so that those listen from further afield are not disadvantaged. Okay. So we've got this report. Okay.
Yes.
And you are taking all the factors into consideration.
Exactly.
From what you said was 3 circumstances or 3 angles.
Triple assessment.
Triple assessment. And then you will stage
the disease.
Okie dokie. Would you be staging if it was deemed to be non-cancerous? Would you still be staging it?
No,
Okay.
No, you don't.
The reason I'm asking that is that then when you hear staging, then it's nearer cancer, right? Or
Then it is cancer.
it is cancer. So at what point, okay, you guys are very calm and, I'm trying to make sure we capture everything. At what point will we get a conclusive diagnosis? After biopsy?
Sometimes after biopsy.
Okay.
Other times will be after the imaging because of how it's looking and how it's caused the adjacent soft tissues.
Okay.
Or is involving the lymph nodes in the axilla.
Okay.
So then you can confidently say this is highly suggestive or suggestive of
Right.
cancer.
Okay.
But even in that stage, the biopsy still has to be done because the biopsy will actually tell you the cell type. Sometimes it will even tell you which the management, which treatments
Right.
would actually help treat the
particular lesions or cells you found.
Exactly.
Okay.
Yes. So with the biopsy can be more conclusive, and then the imaging, depending on how aggressive or how extensive the lesion has become, it can also be conclusive.
Okay, great stuff. The thing I want to ask you, looking at the three of you, the triumvirate, looking at the three of you, so would there be any point in time where I'm sitting in front of the three of you, or am I to assume that there's requisite communication between all of you as those referring and managing my case?
Yes.
Would I sit in front of the three of you, or would I come back and say, look, what Charles said, I didn't like it. Let me go back to AC. When I saw you, your face, you were smiling. But now I've gone to Charles, it looks like, Charlie, your smile is a screensaver. How does it all come together?
Okay.
Because at this point, we are still investigating and coming to a diagnosis. It looks like we've gotten there.
Yes.
Right. I just want listeners to understand at what point this is, should I say, disclosed and shared with the client, and then we'll look at the next steps.
Okay, so management of cancers in general is a multidisciplinary thing. You involve everybody.
Right.
You involve the pathologist, the radiologist, the surgeon, and the pharmacist because of the medication that will come in.
Okay.
When we go into the management.
Yeah.
So if at any point in time, if a radiologist even communicates with a patient, they suspect from their mammogram that is suspicious of malignancy, and if at some point there's been a communication, whatever transpired, the radiologist can always let you know. The surgeons, as for the surgeons and us, all the time we are calling the surgeon.
There's continuous dialogue and consultation.
Yes.
All right.
So you're always aware of what the surgeon is sending to you. there's communication. The pathologist always calls you because sometimes we get the reports and we need the receptors, what you call the immunohistochemistry.
Right.
It's all part of what will influence the treatment.
You need specific, further and better particulars.
Yes.
About whatever you are dealing with.
Yes.
Okay.
Yes.
Right.
So usually, as AC said, there are cell types with these cancers. So maybe the pathologist is done with the report, but we need the IHC for the treatment as well.
Okay.
So the pathologist will also call you, inform you, okay, this will be ready in a day or two. I'm sending in this. This is what I saw. So there's always that communication. Patient is not left in there.
Okay.
Yes.
Right. So there's communication available, and you are able to ask questions of all these highly qualified professionals. If you just joined us 40 minutes past the hour on Joy 99.7 FM, the program is Ultimate Health, your ultimate guide to healthy living. We're going through the steps slowly but surely so that you understand. Phone line is active 030-221-6541. You can ask your questions of my guest. Dr. Charles Ansa Labi is a general surgeon with IMA in Tema. Dr. Anita Owusu-Afriye is a resident oncologist, and Dr. Essie DeGraff Johnson is a radiologist, all from IMA, International Maritime Hospital in Tema. They are my guests today as we plot on in our understanding of the basics, the fundamentals, and some of the specifics of breast cancer. Share with us if you have any concerns. WhatsApp 055 11 11 997.
Joy 99.7 FM.
Okie dokie, let me just see. This one says Dr. Charles and his team are doing a great job. Thank you for the education and coaching. Patrick and Mercy of Focus Creatives. Right, so there's some thumbs up for you, Charles. Very soft-spoken surgeon, very, very soft-spoken. Right. So so we've gotten to this point. There's an understanding.
Yes.
All righty. You've mentioned the team, pharmacist, everybody. You know, how do your patients, clients typically handle this stage? All right, I've got my fingers and toes crossed. I've bound the devil, right? And I'm expectant, waiting to exhale. But yes, we talked about early detection, and sometimes it will catch something. In this instance, it has caught something.
Yes.
How? Share with us what's the reception, what kind of things.
Okay.
All right. Some people ask, should I have come alone? Should I come with somebody? What's it like?
Okay, so mostly the reception is not that good.
Okay.
In fact, there's not even one client I've read the pathology report out to them, explain to them that they have sat down calmly. No.
Okay.
Yes. So most of the times you try to engage them, not to be too anxious.
Right.
You take them through the treatment, you explain everything to them.
Okay.
But everybody and how they handle it.
Okay.
So that's when we involve the clinical psychologist.
Right.
Because some it's too much for them.
You cause the trouble and you bring it to us. Okay, right. So sometimes you need a psychologist, right, to handle the response, to handle even the understanding,
exactly,
all the steps, ahead, right.
So some see the psychologist and some come back like looking good.
All right.
Yes.
They've understood.
Yes, looking very good. Like they are ready. Okay, so doc, where do we go from here? How do we start and all that? So some too will tell you that they need some time.
Yeah.
They've seen the psychologist. They need time to process everything.
Okay.
But we let them know that, the cancer cells are not.
We need to act.
Exactly. They are not sitting there day in, day out. They are just multiplying.
Okay.
So we make that known to them.
Right.
Then at their own time, patient right is always important. Right. So at their own time, some come back. Yes.
Okay, I'm ready to continue.
Yes.
Whoa.
Some too never show up.
Whoa.
Yeah.
I was going to ask about follow-up and what details you have to follow up. This one comes from Dede in Maryland. Dede, thanks for bearing with the technical challenge. I do a 3D mammogram yearly, and then, that was last week. Can I solely, on my own, if it's determined without doubt that I have breast cancer, depending on the stage, to request both breasts to be removed? Right? So you've told me, right? It doesn't matter where it is, whether it is this, take it off. Can I, exercising patient autonomy, right? If I'm in my right mind, tell you guys that, look, all this thing you want to do, go through chemo, radio, come back, this, that, surveillance, watchful, vigilance, please, wouldn't, couldn't, take it off. Can I do that?
It depends on the stage.
All right.
Yes. So,
but do you have the power, the right to,
oh yes,
to counter what I want?
So usually when it depends on the stage, when we stage it, some of the breasts, they are so fixed to the chest wall,
right,
that when you send the patient to the surgeon will send the patient back to you,
right,
that I can't do a mastectomy, that's removal of the breast,
okay,
in this patient. So that's when we do the neoadjuvant therapy. So you start medication, mostly the systemic therapy,
that's
which we all know.
Chemotherapy.
Exactly.
Right.
That's the commonest, but the other systemic therapies.
Okay.
So you start that just to shrink the mass, the lump.
Right.
So that it will be very mobile. The breast is now mobile from the chest wall.
So deny it of it, whatever it's fueling it, whatever it's feeding it, then it shrinks. Then
Yes.
it's more manageable.
Yes. Some respond well to the chemo.
All right.
We've had patients that is attached to the chest wall, but they don't respond to the chemo. So you change it.
All right.
You change the chemo you are giving to them.
Okay.
But whichever way, it depends on the stage. Any breast attached to the chest wall, you send it back to the surgeon. The surgeon will let the patient come back to you.
Okay.
So at that point that you've gotten,
it's not just a snip, cut.
No.
There
You
are
want to make it
indications.
operable. Yes.
Yeah,
You want to make it operable.
All right.
Like a surgeon can operate on it. So if it gets to that stage, you send to the surgeon. The surgeon will also assess that, okay, I'm okay to operate on this breast.
Okay.
At that point in time, if the other breast is fine and you still want a mastectomy for the two, I'm sure the surgeon can do it. Or Labi.
Okay.
Right. So, as you rightly said, that
Right.
management of breast cancer,
Right.
it's multidisciplinary.
Right.
So behind the scenes, even though the patient has left, we discuss the
You have to
case.
discuss the case.
Yeah, with
The individual.
different. Yeah.
Right.
So there is a meeting.
Yeah.
Where you have the pathologist, you have the oncologist, you have the surgeon, you have the radiologist. Sometimes you have the
Pharmacist.
Right.
then you decide
You
what
weigh all
to
your
do.
options. Right.
Yes. So now, like she said, you are going to stage the disease. So if you stage the disease and you realize that it's just in the breast, then you can take out the breast.
Okay.
But if it's outside the breast,
Right.
you can't take it out again.
Right.
So you've gone past the
if the
stage.
disease has spread, right? Even if you take off or away the breast, you still have.
It's already metastasized.
Okay, right. I didn't want to struggle with that pronunciation. Sometimes it catches me. So if we stage it, it's no longer localized or restricted to breast tissue. It has spread beyond there, right? The mastectomy is really redundant, cosmetic.
The benefit is not.
The benefit
really
is not there.
Yeah.
And therefore, the team, after consultations and weighing the options, will now look at the modalities of chemo, radio, and so on and so forth.
Exactly.
Okay. Folks, if you are listening to me, this is important because many of you listen to and maybe do your own distance education, vicarious learning. And you say, this happened to Mansa. I heard her story, and therefore they are going to do this, or they will get here. From my professional, the doctors in the studio are suggesting that no, there's a detailed weighing of your presenting circumstances, your stage, everything, and that may cause or lead to a variation in how your breast cancer, even though it is breast cancer, will be managed as compared to somebody else's breast cancer. All right? Okay. Phone line is the same. That one is the same. Oh, it's not different based on cells and no. 0302 216541. If you have any questions, concerns, experiences, this week you are a bit on the silent side because we've gotten detailed. Yes, Dr. Ansalabi.
So I also want to say that it's not just mastectomy.
Yeah.
You have breast conservation
Conservation,
surgery. Yeah. So with the breast conservation surgery, you are just removing the lump.
Okay.
And then after removing the lump, you send the lump for another histopathological analysis.
Right.
So based on the analysis, now you are going to do radiotherapy.
Okay.
So the radiotherapy is going to remove the residual or the
leftover.
remaining.
Yeah.
Okay.
Okay.
The remaining microscopic.
So you've taken out the significant lump, sent it, had it sorted out, checked, and so on and so forth. And now you will opt for radiotherapy right? To address or attack the cells,
the microscopic
the
ones, those
smaller
that
ones.
could not be removed
Okay.
through surgery.
Right. Okie dokie. Understood. 49 minutes past the hour of 2 on Joy 99.7 FM. Forgive us if we are talking as if we're not talking about human beings or human lives or human tissue, but we want to get you to understand. Good afternoon, Nortey. I went for a mammogram in 2021 and I was told there were lymph nodes in one of my armpits. I went to a clinician and was eventually cleared. Full stop. Is there any cause for alarm? Anyway, I will be going for screening during the month. This is thanks, Mafio in Osu. So something was found in her armpit, right?
Yeah.
Checked out by a clinician and she was cleared. Okay? And she's wondering, is that it? Should I be worried? She has a scheduled screening next month.
Right. So what we always look at is we try to categorize them. So when you look at the American Cancer Society, they have the high risk individuals.
Okay.
So the high risk individuals are those with the family history of breast cancer. Somebody who has had breast cancer before.
All right.
And somebody with the BRCA1 and BRCA2 gene mutations.
Right.
And then of course we have the TP53 gene mutations too.
So these are things that can be handed down, right?
So now
genetic information, right?
Exactly.
If you have these genetic traits, the doctor is taking that into consideration as well.
Yes.
Yep. Go ahead.
Yeah. So you categorize them, and based on the category, if the person is not a high risk individual, then the person can go for the annual mammogram.
Okay.
But if the person is a high risk individual, then the person has to go for the mammogram and MRI.
Okay. So that you can check and scrutinize what is going on.
Yes.
Right?
And
what is present. Right.
And the whole thing about the MRI is maybe there is no lump in your breast. But when you go for the MRI studies, it will be able to pick up some small, tiny lesions.
Right. Okay.
Exactly.
Okie dokie. So the level of scrutiny and of the option or the mode for imaging also helps us catch smaller and smaller things.
Exactly.
Right. Okie dokie. Good afternoon, Nortey. How are you and your panelist doctors? I missed last week's educational program. Please, my question is that people said when you are imaging or x-ray to check whether you have breast cancer, the machine normally destroys some of the tissues in the body. How true is this? Hayford from Bato. So he's asking whether the imaging techniques are themselves not causing any harm to body tissue.
Okay.
Radiologist.
So with regards to that, the dosage that is given or the X-ray dosage used is actually a safe medical dose.
Okay.
That is not supposed to cause any harm.
Right.
But it's not supposed to cause any harm.
Right.
That's the long and short
when
of
you're
it.
doing your imaging.
Yes.
Okay.
The dose that is given to the individual is supposed to help detect these calcifications and these masses in the breast in a safe way.
Okay.
It's not supposed to cause harm.
Right.
Yes.
I guess sometimes people confuse the strength of the imaging technique with what they hear about radiation or radiation therapy.
Yes.
Right. Okay. Can you just clarify which is
radiation therapy is basically under oncology. But that one is at high doses.
Right. Okay. Anita.
So for radiotherapy, mostly the radiation we are giving are very high dose radiation. So sometimes, in as much as it is treating the cancer cells, they have an effect on the normal organs. So anytime we are planning a patient, we have something called planning a patient for radiotherapy. We look at the organs at risk, and we make sure that the organs at risk are not getting dosages that will cause any harm.
So we target the radiation.
Yes. So that one is all factored in, because in as much as you are treating the site of focus, you don't want to affect the other organs around the focus.
Okay.
Yeah.
All right. Yeah. Okay. Hi, Dr. AC. When is it appropriate for women in menopause to do the breast self exam? You only mentioned that of premenopausal women. Thank you, Gloria and Akusumbo.
Yeah, I spoke about
Yeah.
the menstrual cycle.
Mm-hmm.
So for women in their menopausal women,
Mm-hmm.
they always say that a day in each month in a year you can do it. So you choose a day in any month for the year.
Right.
So
that is annually.
yes, annually.
Okay.
But annually is changed when you do the mammogram and there's something.
Okay.
So sometimes there could be something that they will tell you to come in 6 months' time. Or there could be something that you need a biopsy done.
Okay.
Yes. But
So the
if everything is
frequency
fine,
is
it's
related
annually.
to and informed by what has been found
Yes,
and any
yes,
developments
yes,
occurring
exactly.
subsequently.
Yes.
Okie dokie. I'm informed that IMA has free screening on Mondays, Wednesdays, and Saturdays in this
Yes.
month, right?
Yes.
Yeah? Free screening.
Yes, please.
Screening. Okay.
Free screening.
Right. When we say screening, we are looking for possible signs in healthy people, aren't we?
Yes.
Yeah. So you are coming there and you are being screened.
Yes.
Okay.
Yes.
We haven't said free treatment, please. All right. Okay. And then there's a discount on mammogram and breast ultrasound scans.
40%
40% discount.
Yes.
Okay. Me, I like specifics. How much is it before the discount, so that people know they can prepare?
Okay.
So that they know that when they miss the discount, this is what they prepare for, or you don't have the details.
It was 460 something.
All right.
Yes.
Okay.
But now
right.
with the discount is 247.
Okay, you, the stubborn academy people, I'm speaking to you. Stand on your chest. Listen, there's a discount, all right? We don't advertise or promote, but if it's in your interest, we will share the information.
Yes.
It means that for this critical condition or disorder or disease, please, there's some support or help in screening, at least. Okay, take advantage of it. Don't say that, oh, today is what, 8th Metro in Kakra, by now there'll be a crowd. Right. I know Ghanaians, that's how we are. Stubborn academy, we are still fighting over getting national ID cards, let alone free screening or discounted screening. So that's for mammogram and ultrasound.
Yes.
Okay, all in the screening process.
Yes,
Yes.
Okay, none of this relates to treatment. And then there's a follow-up after the mammogram.
Yes.
So that is
Exactly.
also being given free in this month, I've been told. Okay, I poked my nose in there to find out, because you can't just come here, educate us. If there's something good to grab, I'll grab it and inform my listeners.
Exactly.
Right. But I do know, typically I do a lot of stuff with Kolebu, Ridge Hospital. They typically have some of these similar programs of discount, just to encourage
Yes.
and also to enhance access to these strategies that promote and facilitate early detection. Okay, so that you don't even get to, maybe hopefully not to Charles and other people, so that you can, phone line still active, 0302216541. Let me see if I have anything else in my inbox here. We have not gone into chemotherapy proper. We have not gone into radiotherapy proper. We have not even gone into the surgical interventions, whether we are conserving your breast. I'm sure many of you loved it when you heard that term. That Charles will actually help deal with the cancer, but with a view to preserving and conserving breast and breast tissue, because you are worried about how you look. All right. So we haven't gone into those yet, and we know why we've held back on that detailed aspect of it. Okay, Nortey, why is it that during the imaging, the one doing it leaves the room?
So the one doing it is a radiographer. He
Right.
has to leave to go behind the console
Right.
to take the image.
Do you want to bring your family members, members of your year group platform?
And the thing is, if it's not indicated or needed for you to get the X-ray radiations,
You will
it's
not do it.
advisable that you don't.
Okay.
Because there are some people who will just always walk into the hospital and say, I think I have this here, please let me take an X-ray. I think I have that here, please
yeah.
let me lie on the CT machine and then
Right.
just scan
Okay.
and let me see
We're
what's
doing
happening.
serious business here, right? And we're
Yes.
following science
Yes.
and safety and ethics and all
Yes.
that. Okay, so the person does leave the room. Okay, you are the one under the investigation. If there's a biopsy, he will not, the radiologist, the oncologist will not send their sample for biopsy. All right. I hope that is answered. Okay. Right. There's a lot of anxiety and suspicion and misinformation. My horrible tree. That's why he went that's how we will say it. But really seriously, you go to a dentist. If he's drilling your tooth.
Exactly.
Okay, so in this same imaging procedure, it's your tissues that are under examination. I hope we understand it. A tiny piece of a friend's nipple was cut for biopsy. She said it was so tiny you wouldn't notice that there was a cut. All right, so there are different things that are done. Some people hear biopsy, they say like you chopped some give me 2 pounds of liver. But no, it's very, am I right?
Yes.
A very small right piece. Okay, people are worried about these invasive procedures. That's why they ask the questions they do. Okay, even if it's free, discounted, whatever, Charlie, Miss Ro. You see, right? I'm moving closer to something I want to be far away from. So in our education, we laugh and things in the studio, but it is serious business, and we want to capture this and have an impact on the statistics that we keep on reciting to you. Okay, if we could get only 20% of late or advanced presentations, I'll use the same microphone to tell you, right? So let's be sure. Nortey, how often should you have or can you have a mammogram? Matthew and Osu.
It's
Quickly.
yearly. I spoke about the fact that yearly, yes, unless there are issues.
Okie dokie.
Yeah.
All right. So, go ahead quickly.
Yeah. So, yearly. Right? But when you cross a certain age, it doesn't become significant to do it yearly again.
All right.
So when you cross about 55 years,
all right,
then you don't have to be going for the yearly one. You can decide to do it every other year.
Okay. Is that the one that was 400 and something, the mammogram?
Yes.
Yeah?
Yes.
Okay.
And it's now 247.
247.
Yes,
all right.
please. Yeah.
Okay. That gives you some money for emutu, tilapia and things, right? But essentially, do look after yourself. We hope the information provided is helpful, informative, and transformative. Change your choices, okay? With Anita last week, we talked about lifestyle, risk factors, and variables, things you can modify, right? If you don't modify them, they increase your vulnerability. All right, family history, get to know, talk about it, and feel free sharing this information with your friends as well, the same way you share TikTok videos and other things, right? We'll bring the team back or juggle it a bit to proceed into the actual management. Which part is chemo, which part is radio, which part is surgical, and which is the what are the chances and so on and so forth, and what are some of the side effects. You guys like talking about the side effects, but you forget the success stories. So and so lost their hair, but they are alive and they're with us, right? So we'll get into that under the microscope we call Ultimate Health on Joy 99.7 FM. Many thanks again, Dr. Charles Ansah Labi. It's been a pleasure having you, enriching our knowledge and information. And Dr. Anita Usu-Friye, I brought her back. She did a supplementary, right? She wrote the paper again. She's an oncologist with the IMA, and Dr. A.C. DeGraff Johnson. I get stuck, then I remember, we had a vice president. I said, DeGraff Johnson, right? She's a radiologist with IMA. Many thanks for enriching our Sunday. Next, coming up, Man City versus Arsenal. Let me not say anything. The sports guys will be in here, but many thanks to my producer, Abe Kusanko. Please stick and stay on Joy 99.7 FM. Next week we'll be back, like I said. Now we'll break down the different things and all the things that may happen to you as we seek to, manage breast cancer. Okay.